Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Hello, my favorite learners. Welcome back. Another episode of Solo Me, just me, boring. If anybody wants to tackle anticoagulants and is a CRNA in the academic field especially, or has any interest in all things podcasting and talking about anticoagulants, reach out to me. Let me know. Would love to have you on the pod so that my listeners have someone else to listen to besides just me. Okay. So today we're going to talk about anticoagulants, which is a really overwhelming topic for a lot of students, but I'm going to try to break down the coagulation cascade because, to be honest with you, this was the first question I had on my NBCRNA boards. My NBCRNA NCE National Certifying Exam. This was the first question. I was glad I had studied the coagulation cascade. I passed, so hopefully I got the answer right. And here is what we're going to talk about today. So let's get into the actual coagulation cascade. Okay, so we're going to break it down super simply. I say that in every single freaking podcast because that's what this podcast is all about. And what I think is the easiest way to conceptualize things is the simplest format and then building on that molecular knowledge to how our anticoagulation medications work. Okay, so why does the body even have this coagulation cascade, this series of events? And the whole purpose is really simple. Stop bleeding. We want to form a stable clot and we don't want to clot too much. So to do that, the body uses the following things. The platelet. We think of this as the plug. We always hear the term platelet plug. Coagulation factors, which are the glue. We'll talk about all the different coagulation factors. And then the fibrin mesh, which is the reinforcement of this bleeding that needs to stop. So the coagulation cascade is just the body's way of creating fibrin, which is the final step in stabilizing that clot. Fibrin is endgame, guys. Endgame to the coagulation cascade. So the big picture, all right, there are 3 pathways and boards love this part. So here's how you're going to remember it. Intrinsic is inside trauma, and this is measured by PTT, okay? Think damage inside a vessel, intrinsic, triggered by collagen exposure. That's what triggers the intrinsic pathway. Next, we have our extrinsic or our external trauma, and this is measured by PT or INR/INR. Think damage from the outside hitting the vessel wall. This is triggered by tissue factor or factor 3. And lastly, we have our common pathway, and this is where both paths meet to form that endgame, which is what? Endgame is fibrin. Fibrin is endgame. Here's the easiest mnemonic to remember which factors go with which pathway. Okay, so intrinsic is our internal trauma inside the blood vessel. This is 12, 11, 9, 8. 12, 11, 9, 8 joins with 10. Okay, at the end. Endgame fibrin. Extrinsic is 7 and then joins with 10. And the common is 10, 5, 2, 1, endgame fibrin at the end of that. So when we're talking about that common pathway, the easiest way I want you to think of it is it starts with 10, right? You divide it by 2, and that's 5. And so because you've divided it by 2, the next number is 2. Okay, so it's almost like 10, 5, and 2 because 5 times 2 is 10. Okay, that's just how you're going to remember it. Does that make any sense? Okay, it makes sense to me. 10, 5, because you've divided by 2, and 1, because 1 is also half of 2. Okay, does that make sense? I hope that makes sense to literally anyone out there. Sometimes I think of things and I'm like, oh, that's so good. And my students look at me like, that was terrible. But then you have that end of the common pathway is fibrin, because fibrin is endgame. We've talked about that already a lot. So let's talk about this in real language. So the intrinsic pathway, or the PTT pathway, intrinsic equals internal trauma measured by, again, PTT, is associate with medication, heparin. And we're going to go through all the different mechanisms of actions of our anticoagulants in a minute. But the intrinsic pathway starts with factor 12, that hegemon, whatever you want to say, hegemon factor, okay? This activates factor 11, which activates factor 9. Factor 9 teams up with factor 8, and together they activate factor 10. Okay, this is really important for boards, and a little key pearl for boards when it comes to the intrinsic pathway is patients with hemophilia A have that factor 8 deficiency. Okay, so they have an issue with the intrinsic pathway of clotting. Hemophilia B have an issue with factor 9 deficiency. This is also called Christmas disease. Okay, so these are all associated with the intrinsic pathway. So again, we're talking about those numbers with the intrinsic pathway, 12, 11, 9, and 8 to join with 10. And factor 12 is the Hageman factor. Factor 11, factor 9. Factor 9 teams up with factor 8. Yep, and that is the intrinsic pathway in and of itself, okay? And which two diseases impact the intrinsic pathway? And you said hemophilia A and hemophilia B. And hemophilia A has that factor 8 deficiency. Hemophilia B has a factor 9 deficiency, also known as Christmas disease for hemophilia B. Okay, let's talk about, we've gone through, that was the intrinsic pathway. Let's move on to the extrinsic pathway, or that external trauma that the blood vessels are traumatized. I'm dead. The blood vessels are, traumatized. That sounds so dramatic, but the blood vessels are affected from the outside, and that's what makes this the extrinsic pathway, and is the PT-INR pathway. Extrinsic is external trauma, like I said. Seems insane, but yeah. It's measured by PT-INR. What medication? Warfarin, or Coumadin, is impacts the extrinsic pathway. It starts with factor 3. Then that activates factor 7, which activates factor 10. This is why PT and INR is used for warfarin monitoring, or Coumadin monitoring. PT INR goes up quickly. So we know that. We know that we monitor PT INR with our warfarin because it impacts which pathway in the coagulation cascade? The extrinsic. Okay, the common pathway, the final countdown. I like that, the final countdown, because that's a final countdown to fibrin, but also countdowns start at 10 or end with 10, whatever way you're counting, okay? So you start with 10, then it goes to 5, then it goes to 2, then it goes to 1. Those are the factors in that order. So both pathways now converge on factor 10. We talked about that's where the meetup is for the common pathway. Factor 10 and factor 5 form the prothrombin activator complex, and this is really important when it gets down to how these medications work, which converts factor 2 is prothrombin, into factor A, which is thrombin. Now thrombin is the star of the show. What does thrombin do exactly? Basically, thrombin converts fibrinogen to fibrin, and fibrin is what? Endgame for our clotting and our coagulation cascade. So basically, this activates factor 13. 13 to stabilize fibrin, which helps activate platelets, positive feedback loops upstream. So if you can shut down thrombin, you shut down clotting. This is exactly how many of our anticoagulants work and why it's really important. So that is the coagulation cascade. Let's get into our mechanisms of action for our anticoagulants based on what we just talked about with the coagulation cascade. So the name of this podcast is going to be Blood, Guts, and How to Not Cause a Spinal Hematoma, because it really comes into play when we're talking about our neuroaxial anesthetics and when to not do one, essentially, based on the patient's current anticoagulation state. So we just summarized all of the coagulation cascade. So let's talk about where our anticoagulants work in this entire process. So mechanisms of action, because we do not memorize, we zoom out to the big picture, we understand how the actual physiology works and then how our medications impact that actual physiology and what happens in order to get this patient where they need to be in terms of anything, whether it's blood pressure, coagulation status, all of it. We need to know the following. So I'm going to ask you right away a pop quiz question. If I say intrinsic pathway and antithrombin 3, which drug am I hinting at? Yep, you said it, you were thinking it. We are talking about heparin, right? With our intrinsic pathway. Let's talk about the anticoagulants by their mechanisms of action in a way that feels like matching socks, not memorizing random facts. I do not want you guys to data dump. Don't data dump. Don't do it, because then you'll be a provider and you won't know what you're talking about long term. We're trying to commit this to memory, make it stick long term. So heparin, UFH, unfractionated heparin, the amplifier is what we're calling this. So its mechanism of action is it binds to antithrombin 3, which inactivates thrombin 2A and A. This works really fast within minutes. We all have used heparin in the ICU within the hospital setting. We can give it IV or sub-Q. We've given sub-Q. I'm sure everyone's nodding. We've given both IV or sub-Q in the past. In terms of its pharmacokinetics, it is nonlinear. It has it's just unpredictable in liver disease, in pregnancy, and obesity. Those 3 patient characteristics or categories. It is reversed with protamine, and we'll talk about reversal of protamine at some point in this lecture. And basically, the way you are going to remember it is heparin has an H. Heparin is hugs for antithrombin 3, hates A and 10A. I hope that helps with all the H's. So heparin hugs for AT3, hates A and 10A. That's a hater for 2A and 10A. Okay. So low molecular weight heparin, so enoxaparin or Lovenox, is the sniper. So mechanism of action, it also works via antithrombin 3, but prefers A over 2A because our Lovenox just likes 10 over 2. Who wouldn't want 10 over 2? It likes that higher number. So that's how you're going to remember it. It prefers 10A over 2A. And this is more stable in terms of kinetics. So let's talk about pharmacokinetics for a second. It has a 12-hour half-life. It is also renally cleared. So the retrieval anchor that you're going to remember for low molecular weight heparin is less A, more A, because 10 is more than 2. And that's how you're going to remember it. Let's talk about warfarin. So Coumadin, which is the historian. We're naming all these drugs with different little names, so it hopefully helps you remember. The mechanism of action of warfarin, it blocks synthesis of vitamin K. Epoxide reductase, which means it reduces the synthesis of 2, 7, 9, and 10. Okay, 2, 7, 9, and 10 for warfarin or Coumadin. It's a very slow onset. So in terms of the pharmacokinetics, its half-life depends on how slow factor 2 drops, usually 60 to 72 hours. Some sources say, although we know sources say many different things. But it has many interactions. We monitor this with what type of lab? INR, right? We talked about the coagulation cascade and the extrinsic pathway being monitored by INR, which is where warfarin makes its impact. So we're going to remember this by saying warfarin messes with the 1972 factors: 1, 9, 7, and 10. Okay, so I guess one way you can remember this is by thinking about the year 1972. When you think about Coumadin, 1972, although, because these are the factors that it would mess with. But when you think about the 1, it's actually 10. So that's where it gets a little bit confusing. And I don't know if this is the greatest mnemonic, but 1972, 9, 7, 2, and that 1 is actually 10. So that is where warfarin messes up the whole coagulation cascade and why it's an anticoagulant. Messes with those factors. Let's talk about our DOACs, or the specialists, we'll call them, is their little nickname. And these are our direct oral anticoagulants. So our DOACs, direct oral anticoagulants. So these are factor 10A inhibitors. These are our rivaroxaban, our apixaban. Our direct A inhibitors are our I would like to have a word with whoever came up with these drugs. I mean, is it just to make professors sound dumb? I'm confused. But dabigatran. So our direct 2A inhibitors, dabigatran is our main direct 2A inhibitor. Okay, the pharmacokinetics are quick onset. It's renally cleared. No routine lab monitoring is needed. So for retrieval anchor, that you're going to remember this, is if it ends in exaban, or it is affected by 10A or XA, because X is 10. So that means banning XA from clotting. If it ends in exaban, XABAN. Hope that helps. And then our dabigatran is our direct thrombin blocker. Dabi blocks 2 because it mainly is a direct A, or it is a direct 2A inhibitor. So that is how those work. Let's talk about regional timing rules. So talking about how these medications are given and how we are able to do what we need to do as anesthesia providers, although these patients are on anticoagulants. So we're going to talk about these so that hopefully you're not just memorizing a table and you kind of know them a little bit better. So in terms of heparin, our unfractionated heparin, sub-Q prophylactic, if they're just on a prophylactic dose, sub-Q for being in the hospital to decrease their risk of clotting, right, while they're in the hospital, it's a 4 to 6 hours before you can do neuraxial, okay? If it's IV therapy, they need to be within therapeutic range for the PTT. So it's in that therapeutic range for the PTT. We want to stop the heparin drip and check a normal APTT. We want it to be normal. Removing a catheter 4 hours after stopping is the general rule of thumb. So how do we remember this? Heparin equals hours. Short acting, hours, not days. So just know that heparin needs hours in order to be able to do what we need to do. Low molecular weight heparin, so our enoxaparin or our Lovenox, a prophylactic dose is 12 hours before neuraxial anesthesia. It needs to be DC'd. And a therapeutic dose, if they're on Lovenox for therapeutic dose purposes, or they're on that dose rather, 24 hours prior to neuraxial anesthesia. The post-op dose, we want to wait 4 hours after catheter removal. Low molecular weight heparin equals longer, 12 and 24 hours. That's how you're going to remember Lovenox, or low molecular weight heparin, or our enoxaparin. All right, next up is Coumadin, so our warfarin. The INR must be less than 1.4 for a neuraxial anesthetic. And again, this is a general guideline. Each facility usually has their own protocols within their department and their comfortability level of what the INR needs to be. But generally speaking, needs to be less than 1.4 for a neuraxial anesthesia. If the INR is creeping up, we do not want to remove the catheter at that point. So warfarin waits for INR. That's how you're going to remember warfarin or Coumadin. We wait. Warfarin waits for INR. Okay, in terms of our direct oral anticoagulants, so our apixaban, our rivaroxaban, our dabigatran, these are typically 72 hours off before neuraxial, okay? Longer in renal dysfunction because they are renally cleared, so you're going to have an accumulation of that drug for patients with renal dysfunction. Our retrieval cue for this is going to be DOACs, or our direct oral anticoagulants, equals days. Both start with D. Usually 3 days is a safe window. All right, those are our really down and dirty standards for our patients and when we can provide neuraxial anesthetics. Let's dive into reversal agents for our anticoagulants. So let's play reverse the anticoagulant. I'll give you the mechanism or agent and you retrieve the match. So protamine is number one. Protamine is one of our anticoagulant reversal agents. It reverses what medication? Heparin, unfractionated heparin. Partially reverses our low molecular weight heparin, about 60%. Some mechanism is it is a positive molecule that binds with negative heparin. So they make a happy little couple and deactivate or make that heparin ineffective once they are bound together. Our next area of reversal agents for our anticoagulants are our vitamin K or our prothrombin complex concentrate. So let's talk about both of these. So both of these reverse warfarin or Coumadin. Vitamin K is slow. The PCCs are fast. Give both for rapid reversal. Two birds, one stone. Two together, even better. You're going to remember this because warfarin war needs two allies. Vitamin K and our PCCs. Two allies in the warfarin war. Next is actually the third type of reversal agent for our anticoagulants is andexanet alpha. This reverses factor 10A inhibitors. So our apixaban and our rivaroxaban, you're going to remember these because they're anti-10A. Anti-10A is andexanet. Anti-10A andexanet. I had dyslexia for a second. So that's how you're going to remember. They both start with A. They both start with A. Lastly, let's talk about our Praxbind. It has a crazy long name, adarucizumab. That's insane. But also called, probably the brand name is Praxbind. So this reverses dabigatran. Praxbind reverses dabigatran. So there's that. Okay, lastly, let's talk about those coagulation tests again, because we are going to remember, we're not going to memorize, we're going to decode this so that you can commit it to long-term memory. Let's get up behind the logic behind why we do the specific labs. So for PT-INR, This affects which pathway? We've talked about it multiple times in this lecture. Everyone says together, extrinsic. Extrinsic pathway is PT-INR. Factor 7 loves this test. Coumadin or warfarin affects factor 7 the fastest. So INR is monitored for warfarin. So in order to remember this, warfarin is we read the INR. Warfarin, we read the INR. Next lab that we monitor is APTT, and this affects which pathway? Everybody says together, intrinsic pathway. This is where heparin works. We've talked about this again multiple times this lecture. So APTT for heparin. We know this because we've done it a million times in the ICU, right? Patients on a heparin drip, we're doing Q4-hour APTTs. It's very tedious, mostly a one-to-one patient in most institutions because of this. Heparin, that's insane. Yeah, I don't have a good retrieval anchor for that. So you just have to memorize PTT for heparin. That is what we are always monitoring for heparin is PTT. Let's talk about ACT. You will draw these in the operating room if you haven't had experience drawing and monitoring ACTs. These are used for super high heparin doses. So for cardiac bypass, for IR procedures. In order to remember this is ACT for actual high doses. That is what we monitor in the cath lab or vascular procedures. We do a lot of this in the IR suite, basically. The next thing that we monitor is anti-10A level. This measures low molecular weight heparin and DOAC levels, not routinely used preoperatively, but can help in emergent situations to see where we're at. And those are the labs that we monitor. PT, INR with Coumadin or warfarin, because we need to monitor INR with warfarin. We do PTT for heparin. I have no good way of remembering that. You just got to memorize it. And which I hate, but it is what it is. ACTs are for super actual actual high doses of heparin for those specific procedures. And then anti-10A levels are for our low molecular weight heparin and DOACs. But again, not routinely used, but you can do it in an emergent situation or very specific situations. So let's talk about different cases, clinical cases. We're going to talk about what we would do in each scenario. So case 1 is a heparin drip patient. AFib patient presents on a heparin drip for an emergent hip fracture. APTT is elevated. With heparin, we monitor APTT. It is elevated. So what is our plan? Number 1, stop the drip. Stop the drip. We wait 4 hours. We recheck an APTT. We avoid neuraxial anesthesia until that APTT is normal. Be ready with protamine if needed, and consider general anesthesia instead of neuraxial for urgency. For very urgent cases, that is what we would do to maintain the safest scenario for that patient that is on heparin for atrial fibrillation. Case number 2, the patient on rivaroxaban. Their last dose was last night. They need a spinal for a total knee arthroplasty today, or total knee replacement for today. Our plan would be no neuraxial until 72 hours because we have to wait 72 hours for a rivaroxaban. If urgent, we would do general anesthesia with an ET tube. If life bleeding, we can give what medication? We can give our Adexanet. We are going to avoid NSAIDs and ketorolac and plan for multimodal pain to avoid rebleeding. That is our all-inclusive anesthesia plan. The last case we're going to talk about is a patient that is on warfarin with an INR of 2.5 needs emergent abdominal surgery. This would be a bummer, but it just happens, honestly. INR of 2.5 is obviously above our cutoff for neuraxial, which is 1.4. So neuraxial is contraindicated. Giving vitamin K and PCC in order to get this patient to clot faster, because again, those are the anecdotes for warfarin or Coumadin. They fight the war against warfarin, vitamin K, and PCC. Avoid deep blocks until INR is corrected. Use mechanical DVT prophylaxis and consider cell saver because of that risk of blood loss in that case. So 3 questions to strengthen your neural pathways for this very kind of chaotic and dense topic of our anticoagulants and reversal agents. So which anticoagulant is reversed by protamine? What is it? Unfractionated heparin and partly low molecular weight heparin, about 60%, some sources cite, which needs 72 hours before a neuraxial anesthetic. These are our DOACs. Our direct oral anticoagulants. Which test measures warfarin effect? What do we monitor? INR. If you got all these, amazing. If not, even better. It'll help you to remember it in the future when it comes to that retrieval practice. So thank you for spending your workout, your commute, your time outside of courses listening to what I have to say. I hope some of my crazy mnemonics and stories help you commit these to long-term memory, because that is what it's all about, to keep patients safe. The last thing I'm going to say about this whole topic, I guess, is what I do for every single podcast, and that is to give you a word of advice or encouragement to go forth and prosper in the clinical setting today. Today is a clinical pearl and tip, and I tell all of my students this clinically, and I hope that it helps you today. And even if you're a clinician, like, try to practice this and gain a little bit more confidence. But one of my mentors told me this when I was a student, and I always think about it, especially in emergent or crisis scenarios, is ending your sentences with okay for patients. So the patients are at the hospital, they have consented to the anesthetic, they have consented to their surgery, and you will still see a lot of providers go, they will say, I'm going to put this oxygen mask on you, okay? They end sentences with okay. It's almost like this nervous tick for some people, and I've noticed it in myself. So speaking from myself, it's a nervous tick that I have in myself when I'm not confident in what I'm doing. It's just this weird thing that comes out, and it sounds really like a real lack of confidence, okay? So for example, if you have a patient, you say, I'm going to put this oxygen mask on you. It helps fill up your lungs with 100% oxygen, which is safest for you before I get you to sleep. The patient's understanding, the patient feels more confident in you because you sound confident yourself. Okay, so try it. Some people are like, oh, I'm asking for consent to make sure they've signed a consent. They are with us for surgery. At any point in time, they could tell us if they all of a sudden didn't agree to the consents that they've signed, and we would go down that pathway. But that is my argument for why I think cutting the word okay out of scenarios just makes you sound more confident and makes your patients confident in you. So all that to be said, my favorite learners, I hope you learned something today for boards, for life, for practice, and I will see you next time. Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving, and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.